audience.
No, sure. First, thanks, Dr. Ann. Thanks for the invitation. I've known Dr. Ann for a long time, since 2005. He was one of my first students, and he hasn't aged at all. Although I did notice that once he got married, he actually put on a few pounds, meaning that his wife is an excellent cook.
Yeah,
Um, it's been a pleasure working with his group, working up north, working in the center of Vietnam. I certainly hope to come back sometime in the near future. We can start this talk in 1 second. One thing I was going to say is this is kind of a big overview, if you will. So we like to call it the 10,000 foot view. Um, we're not going to go deep diving into a bunch of things. I tried to write this talk to kind of cover both PICU and CVICU, although a lot of the principles and ideas actually overlap. Let me just start sharing this. Hold on 1 second. So tell me if I'm doing this right, Dr. Ron. What I want, hold on, I'll figure this out. All right. Can you guys see that? On, can you see that?
not yet, Cassis. You can share your
Okay.
screen.
That's what I was doing. I thought,
Yeah,
let's see, hold on. Video screen. What is going on here? Oh, share. Okay,
yeah, yeah. I can
now,
see it. I can see
okay,
it.
yeah, now let
Yeah,
me make it better.
yeah, it's better.
Okay, let me get this out of the way over here somewhere. Okay. Anyway, so what I was saying is basically this is kind of a big overview, not a deep dive into any one single topic. We'll certainly come back on a different day and go into more details about other things. So, as you can see, I'm a pediatric cardiologist, cardiac intensivist. I'm actually the cardiology medical director at GE Healthcare at the moment. I was also one of the co-founders of MD One World. I don't have any disclosures that are relevant to this talk. So what I'd like to do is kind of just, this is just a big overview. So I like to say I have three basic rules for both general PICU and CVICU patient care, which revolves around restoring physiology, normalizing cardiac output, oxygen tissue delivery, and then team care. So that's one of the first things we'll talk about. We'll briefly talk about reasons for patient admissions to a pediatric ICU, which are usually medical. We'll talk about reasons for admissions to a pediatric cardiovascular ICU, which are usually surgical. Other considerations for patients admitted to ICUs in Vietnam and other low middle income countries. I've tried to tailor this talk a little bit to you guys and talk a little bit about important pre-existing conditions. Then special considerations for cardiovascular ICU patients, pre-op, intra-op, post-op. Then the general principles again, cardiac output, oxygen delivery management, standardization of care. We'll talk briefly about ICU societies and the future of global medical education and equity, because I think Metaverse is kind of on the leading edge of doing some of this right at the moment. So, Casey's basic PICU, CVICU rules. Rule number one is ICU care is literally all about physiology. So, a PICU patient comes in with some sort of abnormal physiology, either from things like sepsis, respiratory distress, where they have capillary leak, hypotension. So, your job is to try to restore normal tissue physiology. The CVICU patient, essentially the same thing, except a lot of their abnormal physiology is related to cardiopulmonary bypass, aortic cross clamp, which can result in multiple tissue injuries, bleeding, end organ dysfunction, acute kidney injury, etc. Rule number two is ICU care, which goes along with rule number one, is ICU care is all about restoring normal cardiac output and oxygen tissue delivery. So that basically, again, has to do with cardiac output and oxygen delivery, which we'll talk about a little bit later. And if you can restore this, then treatment of whatever the disease process or processes are in the PICU or reversing post-bypass cross-clamp derangement becomes much more achievable and successful. And then the third rule is ICU care is team care. So no one person can take care of an ICU patient by themselves. So we've developed the idea of this, that patients in the ICU are managed by a team. And one of the most important people on the team I found is the bedside nurse. We as physicians walk by, kind of get a snapshot of how the patient is doing at any one moment, while the nurse who's there all the time has a continuous movie, if you will, about how they're doing. So I always want to know what the movie looks like. So at each bedside, when you do rounds, at least in my ICU, the team comes to an agreement on the next 24-hour treatment plan. And we'll expand on that in a little bit. So reasons for pediatric admissions. So in the United States, and this came from a paper published, I think it was, a year ago from JAMA Pediatrics. The median age is 4 years, more males than females. You can see the reasons for they come in: respiratory illness, cardiac failure, sepsis and septic shock are actually lower on the list. Interesting, over 40% of them have respiratory failure on admission, and the length of stay can be greater than 7 days in 40% of them. Now, what I did is I then went and looked at a low middle income country, and I used India from this paper. And here's just a big picture of what all their admissions are. And I think what you see that's different, and it's been my experience when I've gone to lower income countries, and I've seen this in Vietnam too, the vast majority of things that kids get admitted for are actually tend to be infectious in etiology. There is some cardiac depending on what center you go to, but infection seems to be the bigger reason for admission in the lower middle income countries. How about reasons for admissions to a cardiovascular ICU? So the low in the United States, and I've seen this pretty much everywhere I go, everybody has one type of a cardiac CVICU. They either have a pure pediatric cardiac ICU, so no adult or non-cardiac patients, mixed ICUs, so pediatric CVICU is usually part of a larger PICU, and often the patients are sequestered to one side or the other of the unit. And then mixed ICU, where pediatric ICU patients are in the same CVICU as adult cardiac patients. So usually the type of patient, they're usually post-bypass surgical repaired patients. These usually include neonatal repairs such as arterial switch to even repaired adolescents. In a lot of units, including my unit, post-cardiac cath interventional patients who had ASD, VSD closures, valve implants, et cetera, are at least housed there for a night. Unstable pediatric heart failure patients, so in potential need of ECMO or orthotopic heart transplant, tend to come to the CVICU. Difficult to control dysrhythmia patients, and then the patient who's had bypass, who's in heart block, where you're waiting either return of normal sinus rhythm or a pacer implant, but they're depending on an external pacer to stay in the CVICU. Interestingly, most neonates with congenital heart disease on prostaglandins have stented PDAs tend to remain in actually NICUs until surgical repair. So one thing I learned when I first came to Vietnam in 2005 was what do the patients look like? We looked back, I did this with Dr. Zhao and Dr. Phuc, and we published this in 2011. We looked back at our first 5 years when we were at Ho Chi Minh at Nhi Dong 1, and this is what the makeup of the patients look like. And I was interested in the fact malnutrition made up such a huge difference in their presentation, even more than cyanosis or sepsis. So I went and looked at other countries, and this is from data from South Africa, and this was published actually recently as well. They came to the same conclusion: malnutrition contributes to delayed cardiac surgery, poorer short and long-term outcomes, longer hospital lengths of stays, higher risk of infections, et cetera. So when we think about patients coming to the ICU and PICU or CVICU, I think we're worried about what's their disease process, but I think we need to concentrate more also on what's their nutritional status, that even if they're doing poorly, the patient could be put on ECMO and taken to the ICU. So where does the most mortality and morbidity occur? It occurs in the CVICU. So the onus is on us as the ICU doctors to kind of do the hard work. The other thing I've learned quickly is shortage of experienced and skilled CVICU nurses or PICU nurses can most definitely affect patient outcomes. So one thing, while you can work on training patients or work on training doctors, physicians, et cetera, is the nurse training and recruitment needs to be an integral part of that. So what's the special considerations for the CVICU team? Well, ICU care does not start when the patient rolls through the door in the ICU, especially in the cardiac ICU. So we start our CVICU work basically at the pre-op conference. So the case is presented, images, all hemodynamic, the data is reviewed. The surgical plan is discussed and made with the surgeons. The CVICU plan, if there's any worries, is discussed and made. And all team members who are there participate equally in the planning. Everybody has an equal voice. Surgeons, intensivists, anesthesia, nursing. The idea is that you're going to come up with a plan that everybody understands. When we started the program at Nidong 1, I came up with this, I call it the three-legged table. So what has to happen for patients to undergo congenital heart surgery? Well, cardiology had to do one thing. They had to have an absolutely accurate diagnosis for the surgeon. So whatever imaging modalities you needed to use, echo, X-ray, cath, angio, CT, you absolutely had to know what that heart looked like before you sent it to the surgeon. The surgeon's job is to give you the absolutely best hemodynamic repair possible. So this all builds on each other. If you don't have an accurate result or accurate diagnosis, you can't get a good hemodynamic result. So for the surgeon, they need to ensure the holes like VSDs are closed, outflow tracts like in tetralogy are open, valves repaired. We do post-bypass transesophageal echo, and you have to make sure there are no significant hemodynamic, residual hemodynamic lesions. If you have a significant hemodynamic residual lesion, you can't maintain the cardiac output, which you're starting to figure out is my main theme of this talk. So we just tell the surgeon, you're going back on bypass and you're going to fix this till it's right. Once that's done, the job of the cardiac intensivist is, I call it aggressive ICU organ system driven care. We use clinical practice guidelines, which we'll talk briefly about. We do morning rounds. We plan out 24-hour care. We do afternoon rounds or early evening rounds, if you will, just to see if that care plan we're doing is moving along. We aim for early extubation and line removal. So those are the three kind of table legs that make for successful CHD surgeries and great outcomes from your CVICU. So here's just an example of some of the physiology that whether you're in the PICU or the CVICU, where it all almost looks the same in terms of the physiology of maintaining cardiac output. So here's an example of sepsis. So patients come in, circulatory compromise. We've all seen these fever tachycardia, they're tachypnic, hypotensive, they have peripheral vasodilation. They may end up later with circulatory collapse and multiple organ system dysfunction. A lot of times the initial insult is infections, but it could be trauma, poison, malignant, autoimmune. So this results in something that my PICU colleagues like to call the systemic inflammatory response syndrome. And it has to do with this interaction of upregulating and downregulating these cytokines and inflammatory cells. And that's usually a direct result of the insult itself. So untreated, the sewers results in low cardiac output syndrome, increases your peripheral vascular resistance, end up with tissue hypoxia, end organ dysfunction, metabolic acidosis, and if untreated, eventually death. So what's your job as the intensivist? You interrupt and treat SEERS, so the abnormal physiology. So it goes back to the big picture, or Casey's rule number 2, restore and maintain a normal cardiac output and O2 tissue delivery to correct the metabolic and respiratory derangements. If you can do that, you're going to do the other therapies you're going to give, antibiotics, surgery, adjuvant therapies, etc., will then actually work as expected. Same thing with CVIC physiology. So here's an example of the post-op arterial switch, which is well known. So they come to your CVICU early, they're warm, they're well perfused, good urine output, no acidosis. 8 hours later, they suddenly have cool extremities, very low urine output, they're hypotensive and acidotic. And what's the pathophysiology? Well, in these kids, there's two things. First, you've changed their physiology and anatomy. So you've taken a child who had a circulation in parallel, and now you've made it a circulation in series. So they have to kind of adjust to that. And then they've been exposed to cardiopulmonary bypass and aortic cross-clamping with all its derangements. So what's the result? Again, it comes back to something that's a very common theme: low cardiac output syndrome, or the inability of the heart to meet the metabolic demands of the bodies. And a lot of this is caused by bypass and aortic cross-clamping, again, resulting in cytokines and inflammatory cell release, and where cardiac output cannot meet the tissue demands. You also have preload and afterload or pump dysfunction in patients who have been on bypass. So what's the job again? It's essentially the same. Interrupt and treat low cardiac output syndrome. So make the abnormal physiology normal. So again, big picture is to maintain cardiac output and oxygen tissue delivery to correct the metabolic and respiratory derangements. In the CVICU, there's other things you may end up doing: ionotropic support, heart rate, and CBP management. You actually may require ECMO support if they have refractory low cardiac output syndrome. And just a brief word on low cardiac output syndrome. It's basically defined as a clinical condition that caused by a transient decrease in systemic perfusion secondary to myocardial dysfunction. So the basic problem is the heart can't deliver the oxygen needs at the cellular level, and that leads to metabolic acidosis. It's roughly defined as a cardiac output less than 2 liters per minute, but given the kids' wide variation of body surface areas, I don't tend to use this definition very much. It occurs in about 25% of pediatric heart surgery patients. It occurs commonly in pediatric septic shock. And I think what's most helpful is just clinical evaluation. So indirect is urine output acidosis, perfusion. You can do SVC sats. We use NIRS monitoring, which I like. I know some of you have it and some of you don't. I am a big fan of using echo both in the pediatric ICU and the CV ICU. One of my metrics is an ascending aortic velocity. If it's less than 0.8 meters per second, I get a little worried. You also can look at their LV function, and then obviously the direct measure can be a PA catheter. So I said ICU care is all about cardiac output and O2 tissue delivery. This is a good little diagram to remember. So cardiac output is pretty simple. It's just heart rate times stroke volume. Expanding that, basically stroke volume is both preload and afterload. The other things you can do for oxygen tissue delivery, obviously, is you can give them more oxygen. You have to remember that oxygen is a drug, so 100% oxygen over time, if you just leave them on it, actually can be toxic. And obviously, to help with oxygen delivery, if they're anemic, you can transfuse them. One other interesting, I'm sorry, and one last thing I wanted to mention was afterload, which is one thing we actually in the CBICU do have some control over. This was a study actually done by my colleague Tim Hoffman, and we were actually part of this. It was looking at arterial switch patients and what happens to them after surgery. They stuck in PA catheters and measured cardiac outputs every hour. And what they noticed was that about 6 hours, there's a significant increase in SVR. There was also an increase in PVR, but that resulted in a significant decrease in cardiac output, i.e. low cardiac output system. So, but only mildly, the PVR increased, but only mildly. So what that led to was a very mild decrease in cardiac output compared to patients who had very bad low cardiac output syndrome. So we tend to use milrinone routinely. I think dobutamine can work almost as well. So another principle in the CVICU and the ICU is we try to systematically standardize our management. So something we call clinical practice guidelines. And the reason for doing this is we know 100% of the mortality and morbidity occurs there. So we tried to standardize it to both improve care, decrease resource utilization, and just improve patient outcomes. So every physician wasn't doing something different. We're all trying to do similar things. We did this by writing guidelines. We did it for our cardiovascular patients, but you could do it for basically PICU patients. It was written by both MDs and RNs to standardize the patient care, minimize treatment variability, and streamline care. We looked at the data, so randomized control data, systematic review data, and then our own institutional and clinical experience. Clinical practice guidelines are goals, they're care goals. They don't replace clinical judgment. So it's a goal, but it doesn't replace how you think the patient is doing. In our CVIC, they're lesion-based, so ASD, VSD, et cetera. And we organize them into post-op days 0 to 1, 1 to 2. So basically a 24-hour cycle. And again, the CVIC clinical practice guidelines are organ-based, and I'll show you that in a second. And what we developed from that was something we call our flight plan, or big picture, if you will. So the top part of this diagram, you can see, here's the things we expected to happen over the first couple of days: low cardiac output, jet, possibly decreased urine output. And then below, you saw the things we wanted to accomplish using the clinical practice guidelines: decrease their sedation, extubate them, get them off the inotropes, take out deep lines, start feedings, and eventually discharge. And then in the middle of this, you see one of the cardiovascular clinical practice guideline, which I'll talk about in a second. So how do you utilize these? Well, this is what my kind of organ system driven CPG looks like. This is how I organize it in my brain. You can do it any way you want, but I think the way I learned to do it and the way that worked for me was doing it by organ systems, so you didn't really miss anything. So cardiovascular, respiratory, renal, metabolic, heme, GI, ID being one of the most important ones. But you went through every organ system as you're thinking about the child. And then how we did this in the ICU is we'd go on round. Well, first somebody would go on rounds before us. They'd collect all the patient data. We'd review the past 24-hour patient findings and see if those CPG goals were met. And then, while referring to the appropriate post-op day CPG goal, formulate the next 24-hour care plan, again, by organ systems, if the CPG, based on the CPG, if it was appropriate. If the patient wasn't meeting goals, we just reformulated how we're going to do the CPG. This is an ICU rounding sheet I gave my colleagues in Vietnam. Just a simple, basically catches almost everything you want for the past 24 hours. And then we compare what they found to, this is just the cardiovascular, one of the CPGs. But long story short, basically, one of the questions is, are they in sinus rhythm, or in the dysrhythmia, are they paced? And then you look over to the right, and the 24-hour plan would be, maybe you have to do nothing. Do you stop pacing, change to backup pacer, antiarrhythmic medications, adequate cardiac output, et cetera, et cetera. So basically, you have findings, and then you develop a 24-hour plan from that. So what were the results of this? Well, this actually was a study published by one of my residents, who's now a pediatric cardiologist at UC Davis, JEA. And basically what they found is by using CPGs, this was for chylothorax, it earlier time to diagnosis, decreased their ICU and total hospital length of stay, shorter duration of mechanical ventilation. Basically, it made everything much shorter, and it made the patient have better outcomes. When I looked at the data at my institution that I was at, we found by doing this, we could decrease our CV, ICU length of stay, excuse me, for VSDs when I first got there from 5 days down to 3 days. We tended to have decreased intubation time since everybody was using a pathway that we can move along kind of at the same pace. We tend to have faster inotropic support weans and central line and CT removals, which tended to lead to much less infections. And when I looked at it, we had about a 15 to 25% decrease in the use of resources. So chest x-rays, labs, ICU supplies, etc. So we found these very effective. And I think you can develop these for your own hospital based on both the literature and what your clinical experience is. But we found them extremely helpful in streamlining patient care and also in decreasing resource utilization. So societal support for patient management in the PICU and CVICU. I know that Nidong 1 belongs to this IQIC. It was started by Kathy Jenkins at Boston Children's. They now have places all over the world. I think Vietnam, it's Nidong 1 and National Children's Hospital, but you report your data to them, and every 3 months they kind of send you back a report card of how you're doing, and they can compare you to other similar institutions as yourself, and then suggest improvements and things you can do if, say, you're having problems with infections or something like that. And part of the vision was to facilitate a collaborative healthcare team that we can actually, again, more standardized kind of the care that everybody's trying to do. And when you're doing that, you're kind of making everybody's care better. So if you're doing CV surgery, it's easy to join. And I'm sure like Dr. Chow or even Dr. An can tell you how to do it. But I think it's an incredible resource tool. Another support system, I joined this group when it first became a society. This is the PEDS CVICU Society. They have over 900 members, 30 countries. They're actually meeting in San Diego right at the moment. They have an annual meeting. Dr. Zhao has presented, we've presented some posters there. Great resource. They have a website. And I think for doctors from Vietnam, I think it's a very discounted cost to join it, or maybe even free. There's also the World Federation of Pediatric Intensive and Critical Care Society. They essentially have similar goals. They also meet yearly. I can't say I know as much about them, but what I've read about them, they seem to have a similar mission as compared to the PEDS CVICU Society. And finally, one thing I want to finish with, we were at the World Congress last year, a bunch of us, and because we've been all over the world, and we've noticed just the inequity of care all over the world in training. And this is my friend Dominic Vivort. He actually published this looking at the number of pediatric cardiac surgeons kind of worldwide. And you see the United States is densely populated, but you look at areas like Africa or even Asia and Southeast Asia, and not so much so. And basically, the number of pediatric cardiologists and pediatric cardiac intensivists pretty much mirror this picture. So we actually are working on a paper. You can see there's a long list of people here, trying to figure out an innovative approach for global training and equity care. Vietnam's going to be one of the beta testers. I just finished writing a survey that I'm sure you guys will be seeing soon, and we'll help you go through it. It should take you five minutes at the most to get through it. It's going to be on SurveyMonkey. A lot of it's yes, no questions and things like that, but we're really trying at this point to see what can we do to raise the level of care, worldwide, not just in developed countries like the United States. And I think with that, I will stop and we'll see if there's questions.
Okay, thank you for your presentation. Procedure is growing very high, and then with limit resource. So in US there is a ratio between the patient needs surgery and the doctor to take care of the patient. They also set up a ratio for each center or not?
Well, interesting. I actually, having been to Vietnam 30 times, I more worry about the ratio of nurses to patients. Okay,
Mm.
even more that there seems to me there seems to be plenty of doctors, if you want to know the truth, to me. But
Yeah.
nurses, I'm used to patient comes out of the operating room like an arterial switch. It's one-to-one nursing care for a while. If the patient gets better, it's 1-2 nursing care, sometimes 1-4 nursing care, things like that. I don't think there's many ICUs that have anything more than 1-4 nursing care. And we as physicians, we can take care of 4 or 5 patients. That's easy to do, but we're not standing at the bedside every second, usually. So I worry more about the nursing care than I do about the doctor care. The other reason I worry about that, I've been to several institutions in Vietnam where I can see 12 intubating patients and only 2 nurses, and I can't figure out, I mean, I kind of stand there because I can't figure out if one of these kids suddenly coughs out his ET tube, is there going to be somebody there in time to do something about it? So to me, the bigger concern, and it's same thing in the United States and actually all over the world, is do you need more doctors? I think we need a standard of care for the doctors we're training. So, and that's one of the points of the
Mm.
paper I just showed you and the work we're trying to do. But I really
Mm.
worry about the nurses, and that was one of my slides, that if you don't have adequate nursing care, you can have the best doctors in the world, but it just won't matter.
Mm. Okay. And as you know that you say that most of the complication and mortalities happen in ICU and CICU. So in the first step of the heart surgery program, you have any experience to support for the team when they first start up the program, especially
Yeah,
in one country in like
first, I think you do what we did at your hospital. Simple things first, so you can figure out the processes. So we just did, as you recall, we just did ASDs at first, which now half of them we close in the cath lab anyway. But you want to get that team concept out, that everybody feels comfortable doing things. I
Mm.
think the second thing is, knowing these kids are coming in malnourished, the sooner you can start treating that, the better off you are. They will just heal better if you can start dealing with the malnourishment. Some of your kids come in with pneumonia, so you won't take them to the operating room right away. Doesn't mean you can't feed them while you're treating their pneumonia. I
Mm.
will also say that what I found was that a lot of people who had quote unquote pneumonia because they saw something on the x-ray, that was pulmonary edema, that wasn't pneumonia. And there was way too much antibiotic use. You know my feeling about how you guys use vancomycin. It is not water. So I think the first thing it just was like that little table I showed you, the pre-op management as the cardiologist, absolutely accurate diagnosis, and then treat those things you can treat. When the surgeon hopefully does a surgery that, so they close the ASD. Then when it comes to the ICU, what gets every kid in trouble? It's an infection. So the sooner you can get those things out that cause infections, which is primarily the ET tube and central lines, not quite so much the chest tubes and the Foley, but getting those things out like the ET tube and central lines just improves the outcome immensely. And that's one of the things we worked on very hard, is how quickly can you get them extubated? That takes away the ability, when you intubate a patient, you basically bypass all their immune system that keeps them healthy to their lungs, all the cilia, all that stuff that clears out stuff going down your bronchi into your lungs, you bypass when you put an ET tube in. And you also, every time you go in and out suctioning them, you introduce the chance of infection. So any of those things you can do to reduce the chance of infection, I can just tell you by default will make your ICU outcomes better. So if there's one early lesson is get those invasive things out early, and then the other thing is, because I think, like I said, I've seen Vietnam and probably other places use too much antibiotics. If you start an antibiotic, there has to be a start date and a stop date, and you have to have a really good reason to start an antibiotic like vancomycin, because I've seen, oh, the x-ray looks not so right, but does the x-ray fit the clinical picture of the patient? Do they have a fever? Is their white count up? Is their CRP up? Whatever, so I just think you have to be very careful with using antibiotics, only because you start a bunch of antibiotics, the next thing you know, the child's growing fungus. So I am just very judicial with, how you deal with infections. If you think the patient has one, great. I have no problem with it. But there has to be a start date and a stop date. I've been to institutions where there's a start date, and like, when are you stopping this? The patient's been on it for 3 weeks. Like, you got to be kidding. There has to be a date where you say, enough's enough. We have to assess the outcome.
Yeah. So I see some center now we growing with the basic surgery, and they want to go ahead with other program like neonatal surgery for complex congenital heart disease and single ventricle
No,
surgery.
no. Well, my
What do you
gut
think?
feeling on single ventricles, well, I would say you have to be very good at doing big kid surgery before you go to neonatal surgery. Neonatal surgery is a much higher level of complexity. We
Yeah.
did mostly neonatal surgery where I trained and at my institution, and that's a huge team effort, where you definitely have to have enough nursing and experience and things like that. If you want to start neonatal nurse or neonatal surgery, you need to go to a center like National Children's, who does a lot of neonatal surgery, and see how things are done, and then invite them to come help you when you start doing your first few cases. You don't have to do this all on your own. People are there to help you, and there's, I know, teams that come and visit and things like that. But I'll just tell you, neonatal surgery is just a much higher level of complexity. They are incredibly unforgiving if something goes wrong.
Okay. So and for neonatal program, surgery program, I think that's just only limit in some large center, and it's not popular in
I don't,
other.
yeah, I don't think it's a job for the provincial hospitals.
Yeah,
You
yeah,
want to go to a place like, well, like National Children's, Trong's there, and he does a couple hundred arterial
yeah,
switches a year. I mean, and they do well because those guys are just a well-oiled team. They see probably one or two arterial switches every week, so they know what the issues are, what the problems could be, things like that.
yeah,
So you don't want to start your neonatal surgery program by doing an arterial switch if you've never done it before. That's that's doomed to
yeah,
failure.
yeah, yeah, I know. Some center they start with the neonatal first, so maybe they can have some trouble in
If
yeah,
your
in the
neonatal settle
ICU.
wants to do
Yeah,
PDA ligation or something, I'm not so worried about that.
yeah, yeah. I think just basic thing like rotation repair or just PDA
Yeah,
ligation
yeah,
is
yeah. No, that I don't have so much problem with. But when you start doing bypass surgery, where you're talking about an hour and a half on bypass and other stuff, then that's a whole different story,
yeah, yeah. Okay, so thank you so much for your time to share with us all of your experience for a long time training not only in US but also your experience in Vietnam, and I hope you will join with us in the next program. And you have any suggestion for us for the program in ICU and NICU
Right.
in the
Well, I think basically, if people have questions, I'm happy to try to answer them. But also, you guys can work out what things you guys want to talk about next. I wouldn't go for single ventricle and ECMO.
uh, my colleagues are working in ICU that's using Mirinon in low cost, and I think the next topic will be the using of Mirinon in case of low cost post-op. What do you
Sure.
think about this topic?
Yeah, no,
I
I think
remember
that's
for a
fine.
long time
Yeah.
ago.
Yeah. No,
Yeah.
well, we're big fans of Milrinone. So we were part of the study, so we were big fans. So
Yeah, I
but
remember
we
the case in ICU, and I asked you about the low cost in the patient post-op the TOF, and I think other center, other doctor will want to know more about Mirinon using
yeah, I don't
because
think Milrinone's the
yeah,
only thing you do, but I think,
yeah,
certainly if you're thinking ahead and you're worried about a patient, you have
yeah,
that as part of your armamentarium.
yeah. So thank once again, thank you so much for your time, and hope I can see you in the next program. We can share the knowledge and
Yeah,
with Mirinon using.
great. Well, thank all of you as well. It's been a pleasure to talk with all of you.
Yeah, yeah, yeah. Thank you so much,
Okay.
friend.
All right.
Yeah. See
Bye-bye.
you later. Yeah, bye bye.